Okay. I think we'll give it just another minute.
I don't know.
Okay. Thank you everyone for joining. Let's go ahead and get started. And I apologize, the fire alarm is going off in my building, so hopefully it's not too much of a distraction. Of course, it started right. Okay, good. Right when we are about to get started here. All right, well, good afternoon, everyone, and welcome to the second webinar of 2023, supported by the ACCP Immunology and Transplantation PRN. I am Rebecca Dieter, Associate Director of Research for the Transplant Institute at NYU Langone Health, and it is my pleasure to moderate today's webinar. Today's webinar is titled Xenotransplantation, and we are honored to have Dr. Khalil from NYU Langone Health and Dr. Amanda Szczepanik from Eurofins Transplant Genomics serve as our webinar panelists today. Dr. Khalil is currently the Xenotransplant Project Manager at NYU. Prior to transitioning to this role about a year ago, she practiced for 4 years as an abdominal transplant pharmacist at NYU. In her current role as the Xenotransplant Project Manager, Karen is facilitating and overseeing the ongoing xenotransplant research within the Transplant Institute. And Dr. Szczepanik is a medical science liaison at Eurofins Transplant Genomics, a molecular diagnostics company focused on the solid organ transplant population. Prior to joining TGI, she was a clinical transplant pharmacist at the University of Maryland Medical Center. She rotated coverage through all organs that had a special interest in the cardiothoracic population. During her time at UMMC, Amanda was the lead pharmacist on the first in human xenotransplant involving transplantation of a pig heart into a human. In a moment, I will turn it over to Dr. Khalil, but here are a few quick notes. For audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. If at any point during the presentation you have a question for our speakers, please submit them using the chat functionality at the bottom of your screen. And please send your questions directly to me, the moderator of today's webinar, to minimize any possible interruptions. We will take all questions at the completion of the presentation. Today's webinar will be recorded and will be posted on the ACCP IMTR YouTube channel. If you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please just make me aware directly through the chat functionality. And now, without further ado, I will turn it over to Dr. Khalil to begin our webinar.
Thank you so much, Becca. Our relevant disclosures are noted here. I do want to note that xenotransplant research at NYU is supported by United Therapeutics. The objectives of this presentation are to describe the history of xenotransplantation, summarize the various immunosuppression used in xenotransplantation, and provide an overview of xenotransplantation experience from a pharmacist's perspective. So first, let's start with the definition. What is xenotransplantation? So xenotransplantation is any procedure that involves the transplantation, implantation, or infusion into a human recipient of either live cells, tissues, or organs from a non-human animal source, or human bodily fluids, tissues, or organs that have had ex vivo contact with a non-human animal source. So before we get started, I think it's important to run through a quick historical timeline of xenotransplantation, just to see how far we've come. This is not all-inclusive by any means, but I want to point out some major milestones in xenotransplantation. In the 1600s was when the first report of xenotransplantation occurred with the sheep to human blood transfusions. In the 1920s, we have the first report of solid organ xenotransplants. In 1963, Dr. Rimsa transplanted chimpanzee kidneys into 6 patients at Tulane University. 5 kidneys failed within 8 weeks, but 1 patient survived to 9 months with a functional kidney. Around the same time, Dr. Starzl transplanted 6 humans with baboon kidneys at University of Colorado, with a reported survival of 19 to 98 days. In 1964, a chimpanzee heart was transplanted into an adult male by Dr. James Hardy at the University of Mississippi. The patient died within 2 hours, but the heart was deemed to be too small for that adult recipient. In 1984, the famous baby Faye was transplanted at Loma Linda Children's Hospital by Dr. Bailey. The premature infant was born with hypoplastic left heart syndrome, and baby Faye was only 12 days old when Dr. Bailey transplanted her with a walnut-sized baboon heart, and she survived for 20 days. In 1992, Dr. Starzl and his liver team at University of Pittsburgh transplanted a baboon liver into a 35-year-old man with hepatitis and HIV using tacrolimus to decrease the rejection risk. The patient survived 70 days with little to no signs of rejection, and death was attributed to infection. Fast forward to 2021, Dr. Montgomery and his team at NYU performed the first pig-to-human xenograft transplant in an adult brain-dead decedent. Dr. Locke and her team at University of Alabama also transplanted a 10-gene edit porcine kidney into a decedent subject just shortly after. In 2022, Dr. Griffith and his team at the University of Maryland implanted a genetically modified pig heart into a 57-year-old male. And you'll be hearing more about that later from Amanda. And in 2022 as well, Dr. Mozambi and our team here at NYU performed 2 pig-to-human xenograft heart transplant in brain-dead decedents utilizing a 10-gene edit porcine donor. And again, we'll talk about that a little bit shortly. So, as we're all aware, there's a significant organ shortage in the US and worldwide. For this reason, we need to find an alternative viable source for transplantation. Of course, we know there's an unmet need in human organ transplantation, and there are more patients awaiting organ transplantation than donors available, and therefore, unfortunately, thousands of people die each year waiting for their life-saving transplant. So you might ask, why xenotransplantation with pigs? So pigs and humans have been living in close proximity for many years. Unlike non-human primates, pigs have excellent breeding potential with unlimited availability and comparable organ size and physiology. Pigs and humans have been, considerable research has been performed in the appropriate genetic modifications that allow pigs to be immunologically compatible with humans. Therefore, organs from our pig donors may be suitable for our complex transplant candidates for whom an appropriate human match has not been identified. The advent of CRISPR technology, as I alluded to earlier, and the ability to genetically modify our xenograft organs has allowed the advancement of xenotransplant research. There are numerous genetic constructs that are being studied, including a wide variety of genetic modifications. Some of these modifications are summarized here in this table. In order to make our porcine organs compatible for humans, knockout gene edits for specific carbohydrates are necessary due to the circulating antibodies that humans have against these. Most notably, alpha-1,3-galactosyltransferase, also known as alpha-gal, is the bare minimum knockout that is necessary to prevent hyperacute rejection in xenotransplantation. Additionally, human transgenes such as CD46 and EPCR may be added to the pig genome to decrease complement activation and coagulation risk. Now I'll pass it over to Amanda to discuss an overview of immunosuppression in xenotransplant research.
Thank you, Karen. So before we talk about any type of immunosuppression for xenotransplantation, it's important to be able to understand the mechanisms behind rejection in xenotransplantation. So I know a lot of you are familiar with rejection mechanisms behind it and treatment strategies in humans. And so I really only want to focus today on what's different between xenotransplant and humans. There's a lot of similarities, but the antibodies, receptors, and targets are what are different. With xenograft, there's a chance for hyperacute rejection, which, similar to humans, and you'll hear me say that a lot, between minutes to hours is when this can occur post-transplant. And it's caused by the host's pre-existing antibodies binding to antigens on the allograft. And this is mainly directed through alpha-gal and non-gal antibodies. The second type of rejection for xeno is called delayed xenograft rejection. Now, this is going to encapsulate what you're typically referring to in humans for acute cellular and acute humoral rejection. Both of those can occur with your xenograft, and this is days to weeks post-transplant. And when we're talking about antibody-mediated rejection, this is again primarily driven through non-gal or alpha-gal antibodies against the allograft themselves. This is going to lead to triggering of the complement cascade. And I should say, with hyperacute rejection, complement activation is also what's occurring in that early phase post-transplant, causing allograft rejection. Additionally, what's unique about the pig is that there's overlap or shared common epitopes when we're looking at antigens for humans versus swine. And so this is also what can contribute to the development of AMR. When talking about cellular rejection in xenotransplantation, the same molecules involved with cellular rejection for humans are what are present with xeno as well. So your neutrophils, natural killer cells, dendritic cells. And lastly, the third type of rejection is chronic. Unfortunately, with xenotransplantation, there's really not a lot of long-term survivors. So it's not well documented what the mechanism behind this long-term chronic rejection is. However, it's theorized to be predominantly due to low amplitude immune responses. Now, as you can imagine, designing an immunosuppression regimen is very important to use a multimodal approach so that all of these different antibodies, pathways are covered with medications that we're giving. Karen talked earlier about gene modifications that can be done to try and make an allograft more compatible. And so genetic engineering and gene modifications is one very large component of xenotransplantation. But you can't just make gene edits on its own. It needs to be accompanied by immunosuppression. And similar to what we say in transplant for humans, we don't know the gold standard approach. There's no one size fits all. A multimodal approach targeting your T and B cell pathways is going to be important at covering and preventing all types of rejection. Now, the biggest question is, well, what's the best regimen to use? And it wouldn't be a pharmacy lecture without making sure our common classes of immunosuppression are mentioned for at least one point. So I'm not going to go over this slide in detail. I included it more for a comprehensive review of the literature. There are articles published looking at the use of our typical immunosuppression agents like calcineurin inhibitors, mycophenolate, your anti-proliferative, as well as your mTOR inhibitors. But what's unique about these agents in non-human primate xenotransplantation compared to your human transplant is the doses. There's variable dosing strategies and much higher levels of immunosuppression are utilized in non-human primate xenotransplant compared to what we're used to seeing in humans. And so there's a large question, do these doses, do these goals, are they appropriate in humans? Are they effective? Are they too much? And all of those questions are really still unknown. And so the common theme is more research needs to be done. What I would like to comment about the mTOR inhibitors on this table is that if you do not do a gene knockout for growth hormone on the xenotransplant side, there's a potential that that allograft is going to grow in size. And so if you're not doing that gene knockout, mTOR inhibitors, because they have that ability to help with growth inhibition, may be incorporated into regimens for that sole purpose. Now, what I'd like to spend a little bit more time focusing on are the more novel agents that we don't typically utilize in our standard transplant patients. And so when we're talking about a multimodal approach and you look at literature published in xenotransplantation, B cell depletion is a huge component. What research has shown in non-human primates is that B cell depletion is associated with significantly better allograft outcomes, including lower rates of rejection and longer survival, if you adequately and completely deplete the B cells. Since B cells are a main trigger of antibody development, fully depleting them leads to better outcomes. And the anti-CD20 antibody we're all familiar with is rituximab. Now, I've included the dosing strategies for rituximab and all of the therapies we're going to talk about on the slide just for your reference. But what I want you to note is that this dosing strategy is not what we're used to when talking about rituximab for desensitization, antibody-mediated rejection, or even oncology. So it's something to kind of keep in the back of your mind when you look at these doses. It's not what you're typically used to seeing. But about once a week, rituximab dosing starting anywhere from 14 to 21 days prior to xenotransplant is what you'll see for dosing. We're all familiar with co-stimulation blockade, right? When we talk about T cell activation, signal 2 in that pathway of T cell activation. And so co-stimulation blockade is another key component of xenotransplantation immunosuppression. Co-stimulation is required for T cell activation, and I've included 2 pathways on the slide. The CD80-86 receptor coupled with CD28 is a pathway that belatacept is used to help prevent and block co-stimulation. Now, there have been studies looking at the use of belatacept in xenotransplant. However, the data is controversial. There's a few articles out there that do demonstrate belatacept is effective in dampening T cell response and preventing rejection. However, there's also one article that shows belatacept was not effective. So its role in therapy is controversial and still requires, again, more research. Now, the second more novel pathway that seems to be the path forward is the CD40-CD154 pathway. This is also co-stimulation, but it's an indirect pathway for T cell activation. And 2 types of therapies have been developed. One is CD154 monoclonal antibodies, and the other is CD40. Now, CD154 monoclonal antibodies have shown to have prolonged graft survival. However, their main and most important limitation is that CD154 is found on platelets. And so when you give a monoclonal antibody targeting this, you cause platelet activation, consumptive coagulopathy, and thrombosis. So literature looking at these therapies in primates demonstrate thrombosis. And as a result, the focus of drug development has really switched to these CD40 monoclonal antibodies. What's unique about CD40 is it is not present on platelets. So that activation of platelets, that clotting risk, that thrombosis risk should not be there. And as a result, that is the pathway that people have chosen to move forward with in terms of drug development. There's a lot of various dosing strategies with the CD40 monoclonal antibody, and there's also different formulations of it. And so I think that's also important to note that this is something that's still being learned about. The ideal dosing strategy is not still known. And what's unique is when you read some of these articles looking at these therapies, the drug manufacturer, Kiniksa, is actually involved with helping to guide drug dosing and frequency. The last medication class that I want to talk about that also would be what we call our xenotransplant backbone is complement inhibitors. So when we walked through those mechanisms of rejection, complement activation was a core point of all 3 of those. And so because complement is such an active part of triggering rejection and poor outcomes in xenotransplantation, utilizing a complement inhibitor is key. Now, the first complement inhibitor that was available on the market was cobra venom factor. Its main limitation, though, is that its effect was very quick, temporary effect. So then C1 esterase inhibitors came to the market. And you can see the dosing on the slide for your reference for xenotransplantation. And so C1 esterase inhibitors have really been the front runners for what are used in terms of complement inhibition with xenotransplantation. There's also further research being done into various novel complement inhibitors, such as a compstatin analog or tocilizumab. Both of them are targeting various pathways of complement activation, but very novel and still new, and not a lot of data out there looking at them. So before we move on to the decedent model and I turn it back over to Karen, the last thing I wanted to touch on was at least one article that's been published looking at all of these agents used in xenotransplantation. As you can imagine, it's an ever-evolving field. And so every time a study is done, the doses of medications are shifted, the dose changes slightly. And so what I've included here is one of the more recent articles looking at Dr. Mohidan's group, who performed a xenograft pig heart into a baboon. And they utilized alpha-gal knockouts. This was in 5 different baboons. And it may be hard to see on the slide, but the regimen that I've included in here is really what we used as our backbone for development with the human case. And so one point that's important to note is, what were the complications? What did they see in patients on this regimen, and how did the immune system respond? Well, with using a combination of a rituximab, thymo, and anti-CD40 antibody for induction, B cells were effectively depleted for the first 60 days. The rest of the therapy was a combination of the anti-CD40 as well as solumedrol. And no infectious complications were noted in this study, which is important to note because prior studies where doses of other medications such as thymo used at a higher level showed bacteremias and sepsis that led to allograft, not allograft failure, but patient death. And so no infectious complications was important to note with this as well. And with that, I'm going to turn it over to Karen to talk about the decedent model experience.
Thank you, Amanda. So before I discuss the specifics of our xenotransplant research protocols at NYU, I will review the unique pig-to-human decedent model that we utilized. Now, the question you might be asking yourself is, why is xenotransplantation research being done in brain-dead decedents? While a large body of xenotransplant research has been performed in non-human primates like baboons, as Amanda just shared with us, there are some critical unresolved questions in pig-to-human xenotransplantation. First, what immunosuppression regimen is required for acceptable graft survival? Second, what are the essential number and specific gene edits required in the donor pig to prevent rejection, promote acceptance, and produce optimal function of the xenograft in our human recipients? Next, what are the innate and adaptive immune responses to xenografts? And finally, does the pig kidney maintain the appropriate homeostasis of human physiology, electrolyte balance, and blood pressure? These outstanding questions can only be adequately studied in humans. However, currently, concerns about living human subject safety has not allowed for an in-human study. However, brain-dead decedents allow us to study these outstanding questions in xenotransplantation in a safe human model prior to in-human clinical trials. This is a visual representation of the pig-to-human decedent model. This involves a genetically modified porcine organ that is transplanted into our brain-dead decedent. The vessels of the xenograft kidney that you see here were anastomosed to the femoral artery and vein, and the xenograft was left outside the body on top of the thigh for ease of direct observation for signs of hyperacute rejection, and for performance of serial biopsies. A cannula was placed in the xenograft ureter, and the urine output was monitored hourly continuously. This unique model was utilized in our 2 pig-to-human xenokidney experiments that I will discuss shortly. So we know that this research with brain-dead decedents is potentially controversial. However, we have taken extensive measures to ensure this practice is acceptable and performed with the highest ethical standards. Brain-dead donors currently donate their organs for research, and there's a well-established practice of anatomical donation for science and education. We consulted multiple prominent medical ethicists, legal experts, religious leaders who helped advise us during the process and express their support. However, they emphasized that careful attention must be paid due to the perception of research in deceased subjects, which requires openness and transparency. Our strategies for addressing potential negative attention included normalizing this practice within our institution and preparing materials to address media inquiries. This approach has been discussed and approved by the groups listed here. In order for our team to conduct xenotransplant research in brain-dead decedents at NYU, the approval and oversight of various committees was necessary. This includes our NYU institutional leadership, our organ procurement organization, Live On New York, the Department of Health, the FDA, and the IACUC that regulates animal research. Notably, the IRB does not consider a decedent a human subject. Therefore, this research is governed by and under the purview of an IRB equivalent committee called the Research on Decedent Oversight Committee, or RDoC. So first, I'll discuss the earliest protocol at NYU, the pig to human xenokidney experiment. The xenokidney experiment design is outlined here. The objective of the study was to assess the viability of a genetically modified porcine kidney in a brain-dead decedent for up to 72 hours. The primary study endpoints included the function and viability of the porcine kidney in our decedent. Those eligible for the study were brain-dead decedents who were ineligible for organ donation, but hemodynamically stable without active infection, and whose legal representative consented to donate their body for research. We worked closely with our organ procurement organization to identify these individuals and consent their families. We enrolled and conducted 2 pig to human decedent xenograft kidney transplants at NYU in 2021. Both xenografts were genetically modified alpha-gal knockout porcine kidneys with a thymic autograft completed 2 months prior. Both xenograft kidneys were procured at the pig farm, transported on static cold storage before implantation with a cold ischemia time of 6 hours in our first case and 7 hours in our second. As you can see, both xenograft kidneys had excellent urine output throughout the 54-hour experiment, as depicted by the red bars here. The kinetic eGFR doubled after the xenograft implantation, as you can see by the black line. But of note, both decedents had their native kidneys in place for these experiments, so the native urine output is noted separately by our blue bars. There was no evidence of rejection clinically or on biopsy at the end of our 54-hour experiments. Notably, there was no evidence of microvascular inflammation or lymphocytic infiltration on histology as well. About 8 months after the second xenokidney experiment, we enrolled our first of 2 xenoheart decedents at NYU. And before I discuss those results, I'll give a brief overview of that study as well. Similar to the xenokidney study, the objective of the study was to assess the feasibility of using a genetically modified pig heart in a brain-dead decedent for up to 48 to 72 hours. Our primary study endpoints included physiologic function, histologic features, and immune response of our decedent who received the xenograft heart transplant. The eligibility was similar to our xenokidney protocol. We enrolled and conducted 2 pig to human decedent xenograft heart transplants at NYU in 2022. Both xenografts were genetically modified hearts from porcine donors who had undergone 10 gene edit with 4 knockout gene edits and 6 human transgenes that were inserted into the genome of our donor pigs. Both xenograft hearts were procured at the pig farm and transported on static cold storage before implantation with a cold ischemia time of 3 hours and 11 minutes for our first case and 2 hours and 40 minutes for our second case. Here you can see the hemodynamics of our first xenograft heart decedent. As you can see, the blood pressure varied greatly, and the decedent showed some signs of hypoperfusion, requiring high doses of vasopressor and ionotrope support. This was largely thought to be due to the significant size mismatch of our xenograft heart for our decedent human. These are our hemodynamic trends for our second decedent. Overall, a much more stable case than our first decedent, with the heart rate mainly paced throughout. The blood pressure was much more stable throughout the 66-hour experiment, requiring significantly less vasopressor and ionotrope support compared to our first decedent. Now, for those who might be a bit squeamish, or if you happen to be eating lunch, I will warn you that the next slide includes some graphic content, so you may want to look away. So what you're seeing here is the video of both xenograft hearts beating in our decedent's chest. Honestly, seeing those hearts immediately function post-reperfusion was a very surreal moment for me, and it made me hopeful for the future of xenotransplant and really thankful to be part of it. So as you can see here, there was no evidence of ACR or AMR on histology. Of note, there was some endothelial injury and some focal endomyocardial hemorrhage, which is likely due to ischemic reperfusion injury that was actually more notable in our first case compared to our second. Now, I wouldn't be a transplant pharmacist if I didn't review the immunosuppression. So due to the nature of these experiments and the duration of them, the immunosuppression in our xenokidney protocol was minimal and only included steroids and an antimetabolite. The xenoheart experiments, however, also included thymoglobulin induction as well as complement inhibition, in addition to maintenance with our steroids and antimetabolite. All the drugs that we used were FDA-approved medications in transplantation. So in conclusion, we learned a lot from our 4 decedent xenotransplant experiments at NYU. We learned that the decedent model is much better than expected and appears to be possible without the noise of brain death physiology artifact. We had immediate function of all of our xenografts tested so far, with very little change in terms of short-term physiology and hemodynamics, no evidence of coagulation, inflammation, or complement dysregulation. And the alpha-gal knockout appears to be sufficient to prevent hyperacute rejection in these short-term xenokidney cases. There is still much to be learned about the adaptive immune responses. And of course, longer-term studies in our decedents could provide some valuable information that our non-human primate models cannot. And now I'll pass it back to Amanda to discuss her xenotransplant experience at Maryland.
Thanks, Karen. So before we dive into the post-xenotransplantation procedure, I wanted to just give a brief introduction into the patient's pre-operative course. And so this was a 57-year-old male. And before I start, what I will say too is because this is experimental in nature, anything that I'm going to discuss or talk about today is already published either in the literature or through a webinar that's already been performed. So some information is purposely left out just in terms of confidentiality for the experiment. But this was a 57-year-old patient. He was admitted to the hospital for severe heart failure. You can see his ejection fraction on admission was 10%, and his past medical history is noted on the left-hand side of the slide just for your information. But the most important thing to note in that is his history of non-compliance. The patient had been diagnosed with heart failure prior, but was non-compliant with medications as well as medical appointments. When he was admitted to the hospital, he had several complications throughout his stay that ultimately required placement of an intraarterial balloon pump. And even with that, the patient experienced persistent ventricular arrhythmia and arrest, which ultimately led to the initiation of VA ECMO on post-op day 23. He was in the hospital for at least 20 more days, but you can see that with that, several other complications included GI bleeds, bacteremia, and drug-induced leukopenia. Given the patient's state was not likely to improve, this patient was brought to the Hospital Selection Committee for Mechanical Circulatory Support and Heart Transplantation. However, given the patient's long history of non-ambulation and his extensive history of non-adherence, this was a major contraindication to transplantation in mechanical circulatory support. The patient's case was presented to 4 additional hospitals for transplant evaluation, 2 national and 2 regional, all of which denied the patient for transplantation, primarily due to his lack of adherence to his medications. And so ultimately, the xenotransplant team looked at this patient as a potential candidate for xenotransplantation, experimental, of course. And so this was brought up to the selection committee who had agreed to consider this as a possibility. So really the first step was for the transplant surgeon and xenotransplant team to reach out to the FDA and file for a experimental or expanded access investigational new drug application. And this IND did not just cover the procedure itself, but it was inclusive of the PIG from Revivicor. It also included a novel drug therapy called KPL-404 and the ex vivo perfusion system. So they applied for a combined application for this use. Now, simultaneously, there were other pathways or workflows that were going on. So in addition to working with the FDA, there was also a requirement for the ethics team to evaluate this patient to ensure that he was mentally competent to be able to understand what is being explained to him and that he's able to give consent. So there were 3 separate institutional evaluations and 1 external independent psychiatric evaluation that reviewed this patient and ultimately deemed him able to provide consent. The FDA granted approval as long as the institution, so University of Maryland's IRB, reviewed the proposal and approved it as well. And then one of the other big processes for this to be approved was really designing an immunosuppression regimen for this patient. And that was the point that I had gotten pulled in. And so what I was provided was a list of medications that you can see here on this slide, and was asked, can we do this? Can you order it? What do we do? And so as you can imagine, as a transplant pharmacist, if you give me a sheet of paper with all of these drugs and all of these doses, my head's going to explode. We don't typically use these agents. And if we do, well, we use some of them, but not certainly all of them in combination and at the doses that are listed on the slide. So as any transplant pharmacist would do, you go to the literature. What do we have published and what can we extrapolate to this patient? And most of the literature that's published, or I should say pretty much all of it prior to this point in time, is non-human primates. So is what's published in non-human primates, is that translatable to humans? Can we just move it and apply it to humans? When we talk about non-human primates, the level of immunosuppression that they require to prevent rejection is much higher of a requirement than what's used in humans. And so really the first step was looking at that xenotransplantation literature and then looking at, well, what's been published in humans? Rituximab, what do we use for AMR? What do we even see in oncology? What other doses are there? Thymo, everyone's pretty familiar with. Berinert, I had to look up a little bit more. And so what I did is, you compile all of this information and you bring it back to the team and you sit down and you talk about it. And so what you can see in red and some of the strike throughs are the modifications that were made. And some of these therapies, again, are what I showed you earlier in the presentation with that case where you had 5 baboons receiving a pig heart undergoing therapy. And so we transitioned the rituximab dose to be more in line with the standard treatment strategy for antibody-mediated rejection. The biggest difference here is that in xeno literature, most often it started 1 week, 2 weeks prior, but we didn't have that kind of time. So this ended up being given within the week right before that transplant procedure. Thymoglobulin was used around a dose that's a little bit more in line with what we're used to seeing with transplantation. So a dose of 1 to 2 milligrams per kilogram each day, of course, based on lab counts. KPL 404 is that anti-CD40 monoclonal antibody. And what is unique about this is we had a standard dose to start with. So the company, Dr. Mohidan and the team had worked with the company to be able to identify what dose was recommended for starting. But subsequent doses were guided by drug levels in conversation with the pharmacist from the investigational drug services team, the transplant team, and the drug manufacturer. So I'm not including that information just because it wasn't published, but they did utilize the Kiniksa drug manufacturer to help guide dosing strategies. Berinert is an expensive medication and one that I personally wasn't familiar with using often in transplantation. So I relied on published dosing that we've seen in other human literature and then rounded to the nearest vial size to minimize medication waste. Tocilizumab and etanercept are both agents utilized to prevent or help with inflammation, but I've never really seen these used in terms of a maintenance immunosuppression strategy with transplantation. And in all of the non-human primate xeno literature, it really wasn't recorded or documented frequently in those populations either. The other part, as pharmacists, that we're all aware of is drug shortages. So this was also in the time of COVID, right? And so tocilizumab was on shortage. And so it was really hard to even work talking with the Department of Pharmacy to utilize these agents when we didn't have a lot of data to support their use in this fashion. And so ultimately we ended up eliminating tocilizumab and etanercept from that regimen. You can see the maintenance regimen. I'm not going to talk as much detail about this because the doses are what I had showed previously for induction. But again, you can see the changes that were made based on literature and combinations with the Department of Pharmacy as well. And so really what was interesting was seeing how the KPL 404 was dosed and driven through the drug company as well. I also included in the lower left-hand corner the opportunistic infection prophylaxis. We went with ganciclovir for CMV, isavuconazole for fungal, and atovaquone for PJP prophylaxis, primarily because the patient had really low white counts. And then in terms of antibiotics for surgical prophylaxis, the bigger the gun was, the better, because my concern looking at this regimen was, are we going to increase this patient's risk for sepsis by giving him all of these therapies? So let's just be broad to start and we can tailor from there. So we ultimately started with vancomycin and meropenem. Now I could talk for an hour, or the team could talk for an hour about what happened to this patient or longer post-transplant, but I really only want to try and hit some of the high points and what would relate to us as pharmacists. So the pig itself was actually delivered from the Revivicor facility in Virginia to University of Maryland. This was a 10 gene edit pig that was designed to help make the graft more compatible for humans. And really the major complications early on were the patient's lab abnormalities. And so the patient had thrombocytopenia and neutropenia prior to transplant. Patient was on ECMO, lots of infections, getting multiple rounds of antibiotics. And so he had a very complicated pre-Xeno course, and that was going to lead to complications with dosing medications post-op, right? So platelets are in the lower left-hand corner, and now I'm adding in the white blood cell count and ANC trends. So you can see early pre-transplant levels were low. Post-procedure, as would be expected with any type of surgical procedure, white count rose. Patient was really stable post-transplant. The biggest problem early on was the low platelets. And so that's really what guided our dosing for thymo in terms of reducing the dose for platelet count. But around post-op day 15, you could start to see the white blood cell count and ANC downtrend. So as the pharmacist, it's our responsibility to observe and look at a patient's drug regimen for causative factors. ID was involved, thinking about, are there viral etiologies of this neutropenia, this leukopenia? So everyone kind of got together and said, what could be causing this white count drop? Well, the patient's on ganciclovir, the patient's on mycophenolate, patients on all of these medications that we really can't adjust because we're playing the line of rejection and infection. We kept watching that white count downtrend, and then around post-op day 20 was when GCSF was administered. However, because the white count and ANC had dropped so low, there was also a heightened concern of infection. And so ultimately the mycophenolate was discontinued at this point in time as well. So bear in mind that now the patient was on KPL 404 and corticosteroids only for immunosuppression management. It doesn't sound like a lot, and that's something that's nerve-wracking, but the xenotransplant team was performing flow cytometry, looking at the patient's B and T cell counts to determine if the patient was adequately immunosuppressed. And so the patient continued to do well post-operative. He was able to rehabilitate without any cardiovascular support. His graft was functioning, he was communicating, he was smiling, and he was doing really well. The team on post-op day 34 decided to do a biopsy, and the biopsy came back clear. No evidence of any type of rejection and no abnormalities. The patient continued to do well until he reached post-op day 43. At that point in time, the patient became somnolent, hypotensive, requiring fluids and vasopressin, and ultimately was intubated for airway protection. Part of the surveillance strategy that the team utilized was looking at microbial cell-free DNA. And so they looked at common human viral pathogens, but also a few research porcine pathogens. And from this microbial cell-free DNA, they were able to identify an increase in porcine CMV viral load. Now, this was a surprise, and it's a question because it's not well known that can porcine CMV be translated and given to humans. And so they looked at the spleen of the donor and they looked at the PBMCs from the recipient to confirm this result, and both came back positive. So there was a concern that the patient was experiencing a porcine CMV infection. As a result, since the patient had been on ganciclovir, therapy change was performed. Now, the question is, what therapies do we use for porcine CMV? There's not a lot of data out there, especially in humans. And so the two core therapies that really have been shown is ganciclovir and cidofovir. Well, the patient had been on ganciclovir. Dose had been changed based on renal replacement therapy, oral to IV, depending on how his gut was functioning. But he'd been on ganciclovir for a long period of time and the viral load increased. So after consultation with infectious disease, the team transitioned to cidofovir on post-op day 43. At the same time, they had checked an IgG level and saw it came back at 185, which is low. They administered IVIG 80 grams, which is a 1 kilo per kilogram dose on day 43 as well. The next couple days, the patient improved. He was extubated, his blood pressures normalized, his graft functions appeared to be stable. And then you fast forward a couple more days later to post-op day 49. And again, at night, the patient became hemodynamically unstable. Hypotensive, requiring pressors, respiratory distress, requiring reintubation, a rise in serum lactate, and ultimately the team decided to perform a second biopsy. So on the left side is the post-op day 34 biopsy, clean, negative, no any type of allograft injury evident on that biopsy. Post-op day 50 is there in the middle. When they looked at the biopsy, they saw no evidence of cellular or antibody-mediated rejection. They saw no C3D or C4D deposition, but they did see focal capillary damage, extravasated erythrocytes, edema, and antibody staining demonstrated presence of immunoglobulin G, or IgG. So when they coupled this information together, along with also seeing a rise in serum troponins, the team decided that this patient may have atypical AMR, and they pursued therapy. One of the problems with xenorejection is once it starts, it's really hard to treat. So they opted to treat, and the patient kind of got the kitchen sink because they really wanted to try and see if they could reverse or prevent worsening of this injury. Patient underwent plasmapheresis, IVIG, repeat doses of the C1 esterase inhibitor, eculizumab 1 dose, and rituximab, all while still being supported on ECMO. 6 days later, they decided to rebiopsy that patient and unfortunately saw progression of tissue injury on that biopsy. They saw AMR grade 1, C4D positivity, and while there was a slight reduction in red cell extravasation and edema, there was a significant increase in myocyte necrosis. Ultimately, the team had decided that there was an irreversible injury that was present that the patient was not going to recover from. And so in conversation with the team and the patient's family, they decided to withdraw care on post-op day 60. Well, what do we take away from this case? What did we learn? A lot, right? You know, there's a lot of questions that were identified and a lot of research that can be done going forward. So when looking at the patient's immunosuppression regimen at the beginning, it appeared effective in managing his rejection risk. However, the pronounced sudden diastolic failure and myocardial thickening was not able to be explained. It's not something typically seen in human transplantation, and there's studies underway really to try and identify mechanisms responsible. Questions that really came from this were, what is the role of porcine CMV in humans? Can humans develop this? Did it play a role in what happened with this patient? The other question that came up is, what is the role of IVIG? There was development of anti-PIG antibodies, so could this have played a role in what happened? And so further research really needs to be done on all of these questions to identify what was the cause of this decompensation and ultimate failure. The last part that I touched on the prior slide, but just want to drive home, is that rejection in xenotransplantation is very difficult to treat. And once you diagnose it, or once it's identified, it's almost near impossible to be able to effectively treat it. And so prevention is really key. Now we're going to quick transition over to what is the role in xenotransplantation. This is a field that is not going anywhere. There's only going to be further research, further attempts at doing this. And so what does a pharmacist do? And I'll talk about my experience, and then I'm going to let Karen talk about her very unique role too. So as the xenotransplant pharmacist, if you're ever in a situation where you're managing a xenotransplant last minute, what do? Well, it's pretty much the same thing that we do on a day-to-day basis with our human transplants, right? You're responsible for looking at medication dosing and renal adjustment. The big thing with this case is, how do you give all of these therapies together? So IV compatibility, duration of infusion, stability of medication after compounding, these are all questions you really need to think about, because some of these, or most of them, are all extremely expensive medications with short stability. So I had created a PDF that outlined all of the therapies, timing of administration, and duration of infusion to try and make something that everybody could reference and make sure everyone was on the same page. The other question is, what's the correct order of giving these medications, right? So if you give them in the wrong order, could you negate the mechanism of action of one of the other agents? So there's not really a lot of data that's out there. And it was really just bouncing ideas off of the transplant pharmacy group and Department of Pharmacy and the transplant team and the Xeno team to make sure everyone was all in agreement with what the right path forward was. Communication can't be said enough. The number of people that are involved in something like this is huge, right? No one person can do this. It takes a village. And so investigational drug services, we had an IDS pharmacist that worked very closely with helping to identify timing of the medication, compounding, and delivery of the medication. We needed to know, when were the pharmacies open to compound these products? Who was going to deliver it? Who was going to do the handoff? And so this was all information that needed to be identified and solidified before any of this could move forward. And the last thing I did was just enter the orders of medication ahead of time and save them to try and minimize order entry error. And I communicated that with the nurse practitioner, but it's definitely leaning on all of the different departments and your colleagues to be able to really make this happen. And I'm going to pass it over to Karen to let her talk about her experience.
Thank you, Amanda. So if you're wondering what I do as a xenotransplant project manager at NYU, here's a high-level 1,000-foot view of a day in my life. So a big part of my role is facilitating the experiments from a regulatory perspective. And that means corresponding with all the appropriate regulatory bodies that I kind of alluded to earlier, the IRB, or RDoc, the OPO, the FDA, the NIH, just to name a few. I also contribute to the study design and protocol development, of course, also focusing on the immunosuppression protocol. Similar to clinical transplant pharmacist role on an interdisciplinary team, I'm also involved in thinking about patient selection, what strategies we need to use to prevent infection, of course, immunosuppression to prevent rejection, and how we can increase access to transplant. During the xenotransplant cases, I oversee and coordinate the laboratory procedures with our basic scientists and kind of oversee the experiment as a whole. From a publication perspective, I assist with data analysis and coordinating and contributing to our manuscript preparation. And I'm also currently involved in facilitating some grant proposals. So what are the next steps in xenotransplantation? So there are definitely unanswered research questions that require additional preclinical experiments, as you can probably conclude from all the data we presented thus far. First, we need longer-term studies to determine the humoral and cellular responses after 2 to 4 weeks. Second, we need to determine the appropriate gene construct that we need to use for each specific type of organ. And last, but certainly not least, we need to identify the appropriate immunosuppression regimen. These are all necessary questions that we need to answer in order to move forward with our first in human or phase 1 clinical trials in xenotransplantation. We will then, of course, need to discuss patient selection and determine the appropriate candidates for xenotransplantation. With the goal of creating a centralized donor center to facilitate procurement and transport of organs all over the country, it really feels like the possibility and impact of xenotransplantation are endless. And I hope this presentation left you just as excited about the possibility of xenotransplant as we are. And before we conclude, first and foremost, I'd like to thank the donors and their families for their wonderful gift and contributions to research that will help us advance transplantation and improve patient outcomes. Amanda and I have listed some of the incredible teams that were part of the heroic efforts at both NYU Langone Health and University of Maryland Medical Center. And as Amanda mentioned earlier, when we say it takes a village, it truly does. And of course, a thank you to our sponsor, United Therapeutics, because these experiments would not have been possible without their support. And with that, thank you for listening, and I'll turn it back over to Becca.
Thank you both for that very exciting presentation and for sharing your very unique experiences with us. I think that it's just amazing to see how far we've come in this emerging field, and to know that pharmacists have been a key part of it and will continue to be a key part of it as it moves forward is just amazing. So thank you again, both, for taking the time to share that with us today. We have about 5 minutes for questions, and just a reminder for the group to just send me any questions that you have for our speakers in the chat. Our first question, I think could be for both of you. If you want to start, Karen. Similar to human pre-transplant workup, including the cross-match, DSA, PRA, et cetera, is there pre-transplant antibody testing that's done or being studied for xenotransplant, such as the anti-alpha-gal antibodies? And are these naturally occurring antibodies, or do they develop de novo?
So that's a great question. And actually, there is a lot of research being done by our group and others about how we should work up these patients for xenotransplantation. So there is a cross-match that we conduct. We do look at our antibodies the same way we would in our, patients in standard clinical care. And these are naturally formed antibodies within us. And the concern is this memory response or hyperacute rejection. And that's why, as I mentioned earlier, the bare minimum that needs to happen is an alpha-gal knockout, which is a carbohydrate that we discussed briefly.
All right, thank you, Karen. And Amanda, do you want to speak at all to any of the testing that you did for the living transplant?
Yeah, so I mean, I was only pulled in about a week before the procedure itself happened, so I was not part of the conversation related to cross-matching. I just know that the Xeno research team has done a lot of research into what are the correct gene knockouts to do to try and improve the compatibility of the organ with humans. And they did do DSA monitoring, and they also did do post-transplant novel cell-free DNA monitoring as well, to try and pull on more novel technology for monitoring, but that was the only part that I was involved in.
Thanks, Amanda. And our next set of questions are for Karen. The first question is, with regulatory hurdles existing to move xenotransplant forward, does the current immunosuppressive strategies borrowed from the non-human primate models limit expansion, given that many of the agents are not FDA approved for transplant?
So that is a great question, and one that's come up a lot actually in the field. So I think that the fact that a lot of these drugs are experimental does give the FDA a little bit of pause when it comes to evaluating, how we can utilize these drugs in humans. And because all the data we have is in non-human primates, as you saw with Amanda's presentation, it's really hard to translate that to our humans. So for that reason, actually, I truly feel, and yes, I'm biased, but that the decedent model is a great way to start testing this, where we're not putting humans at risk and we can start testing these drugs. But I do feel that just in kind of knowing what's been going on in the field, the FDA is pushing for trying to optimize the approved drugs and potentially moving forward with some of the newer agents that are out there for co-stimulation, which is definitely going to be a part of any regimen, I think, that we'll be using in our first in human.
Thank you. And then the second question is, will centers leading the study of pig to human xenotransplant alter immunosuppressive strategies from what's published to potentially help with the FDA approval of xenotransplant?
That's also a great question. And I think it's hard because there's definitely some bias in the people who have been in the field for a long time and the way that we interpret the data. So if you ask some people, they might say that, we failed calcineurin inhibitors and we shouldn't try that again. But in reality, we don't know what levels we should be targeting. And maybe the studies that were out there already were targeting low levels for non-human primates because they were trying to kind of adapt it to what we would do in our patients, which might not be sufficient. So I think there's a lot of outstanding questions in terms of, what we need to test, how we need to test it, and really determining what the optimal kind of balance of genetic modifications where you can knock out complement, knock out some other things that might prevent activation of coagulation risk, complement inflammation, but then also balancing that with what immunosuppression regimen is ideal. And believe it or not, there's already talks of tolerance in this. So of course, that's like the future of all of transplantation, but definitely something that has been discussed even in Xeno. So I think there's a lot to be learned. I know that was kind of a roundabout way, but hopefully that answers the question.
Thank you, Karen. And then the next question is, and I know we're at the top of the hour, so we will try to squeeze in a couple more. Are the investigational medications being used in xenotransplant also being investigated for typical human transplants as well? And then Karen, do you want to start with that one?
Sure. I will tell you that some of those medications are being studied right now. They're in the early phases, but I won't be specific, but there are some out there that are currently being studied. And it'll be interesting to see how that plays out.
And then Amanda, would you be able to speak about the investigational agent that was used in your protocol?
Yeah, so the investigational agent that was used was an anti-CD40 monoclonal antibody. And so it was actually a ligand, and supposedly that portion, and I don't know if I can go into too much detail because again, it's just limited to what's been published, but the ligand is supposed to make it bind and adhere better. So you're supposed to be able to get better effectiveness utilizing that formulation of the CD40 antibody versus past formulations that have been studied. This therapy has been shown to have better rates of rejection and prolonged survival compared to alternative CD40 antibodies that have been produced in the past.
All right, great to know. And the last question, and if anyone has additional questions that we weren't able to get to, please feel free to email and we can have our presenters, Amanda and Karen, respond via email. But Karen, as you're at the forefront of leading research in xenotransplantation, do you foresee this as an area that more transplant pharmacists will need to be involved in as the field progresses?
No doubt about that. I think that, as you can see with the crazy amounts of immunosuppression, maybe to our Xeno researchers is not crazy. I think that pharmacists need to be involved in this. I think that not having a pharmacist weigh in on the dosing and how to administer and the order for it would be kind of horrible, for lack of a better term. I think that once xenotransplant reaches the clinic, there will certainly have to be a pharmacist as part of that team. And I don't foresee kind of the FDA and any regulatory body kind of not agreeing with that.
That is very exciting to hear. I think we can all agree on that. Well, thank you again, Dr. Khalil and Dr. Szczepanik, for presenting today's webinar on xenotransplantation. It was an excellent presentation. And just a reminder for everyone, this webinar will be posted on the ACCP IMTR YouTube channel.
Thank you very much for the opportunity.
Have a good day, everyone.